Good morning, everyone. Well, thank you for coming this morning. I want to introduce, and you probably already know, Dr. Earl Guthrow. He's here to speak on adult um, onset diabetes. So let's give him a warm Westminster Canterbury welcome.
Hooray. I wanted to thank Denise for inviting me to do this and for y'all to come. And I have a couple of notes. You have to understand that I haven't practiced medicine since 2006. So I've not been always incredibly I've not always felt like I've had to keep up with every new development. So you have to put that in a footnote. But I did go back and review all the latest stuff that I could find on type 2 diabetes. It took me about a week, not continuously, but I spent some time on it. And there's some, interesting things that are going on. And the the second thing is that it's hard for me to answer specific questions from patients about their personal medical problems. And the reason for that is that I don't know your whole history, and I don't want to tell you anything that's misleading. I mean, I'm glad to talk to anybody about anything, but I might not tell you anything back. And I'll just say, you need to go see your own doctor. Um, so, because I think that's the fairest thing for you, really. And I did prepare a handout, which I hope everybody has, and I tried to make it somewhat entertaining and fairly straightforward, although I'm sure that in parts of it, you'll have questions about things. So why don't we get started? The first thing, the general outline of this is I'm going to talk a little bit about what goes on normally in our bodies, and then what's the problem with type 2 diabetes. And then, of course, we'll go through the treatment, complications, and all that sort of thing. I'll talk a little bit about how human insulin is made with recombinant DNA technology, which is really quite amazing these days. And then because there's a process that goes on in diabetes called glycation of proteins, it's also biochemists and organic chemists and endocrinologists think may be related to aging processes, especially wrinkling of the skin, but many other things as well. And they're really kind of related. So anyway, by the way, you might notice that on this, when we staple this together, the page numbers, the odd page numbers don't show, but the even ones do. But so I suspect that you'll be able to subtract one when there's no page number. If I say, page 3, like I'm going to say right now. Anyway, when we eat a meal, a lot of it has sugar or it has carbohydrate in it that can be broken down into sugar. The sugar is absorbed and gets into our bloodstream. It goes around to our pancreas. There's a mechanism where the sugar stimulates the release of insulin. The biochemists have figured out a lot about how that works, but I'm not going to get into that. The insulin then goes out in the bloodstream and it floats around to muscle cells, fat cells, and liver cells. And it sticks to the outside of those cells on a little area called a receptor. And when it does that, it initiates a cascade of events in the cell that open a pathway in the cell membrane for sugar to go into it. And you can see that on page 4 and on page 3 as well. So insulin is sort of like a key that goes in a lock, and when you turn the lock, a pore opens in the membrane and sugar goes in. And It's a very efficient system. It works very well when we're healthy and don't have diabetes. It's really kind of, in my view, amazing that we've been able to figure all this stuff out over the last 50 years, really. Going on to page 5, there's a sort of a cyclical process in controlling blood sugars. When our sugars go up, that stimulates the release of insulin from the pancreas. The pancreas binds to the cells of muscle cells, fat cells, and liver cells, and sugar goes into the cells, and the sugar drops. Now, if it drops a little bit too low, then glucagon is secreted from the alpha cells of the pancreas, and that causes the breakdown of glycogen, which is a stored form of sugar, and that's dumped out into the bloodstream, and the sugar goes back up. So this circular process that's going on in our bodies all the time. And the next thing we might want to talk about is, why do we need sugar in the first place? What is it doing for us? And on page 6, there's a little discussion of that. Basically, sugar is metabolized in a way that allows and causes the production of ATP, adenosine triphosphate. And it's a compound that has 3 phosphates on it in a line. And in the bonds of those phosphates, there's an enormous amount of energy. And when the terminal phosphate is clipped off, an amazing amount of energy is released. And that energy is then used to make things happen in our bodies. Muscles contract, nerves do their signaling process, and so forth. So sugar is really very important in that process. There's some other compounds that are important in nutrition as well, but we're not going to get into that because we're talking about diabetes. But ATP is an incredibly important compound in our bodies, and it really is the fuel that makes everything work. So anyway, we've talked about normal. We've talked about why we need sugar. So what's going on with type 2 diabetes? Well, the real answer is we don't know what's going on with type 2 diabetes. But the biochemists and the endocrinologists and the organic chemists and other people have tried to figure it out as best they can. And one thing they figured out fairly early on is a way to measure binding of a hormone or substance to a cell membrane. You can actually get a number out of that. And so they obviously did that with insulin. They took some fat cells out of somebody's abdomen, and they went back to the lab and they started measuring how tightly insulin bound to the fat cells in people who didn't have diabetes and people who did. And lo and behold, they found that in people who had diabetes, the insulin didn't bind very well. And so they call that insulin resistance. The cell is resisting the normal effects of the insulin. So when it doesn't bind, there's no signal generated into the cell to make the sugar pore open, so sugar can't come into the cell. Now, usually that's associated with people who are overweight, and we don't know why that is. The way I've always thought about it is maybe a little piece of fat around the receptor flops over in the keyhole, and and the insulin can't get in. But we don't really know. But what does happen is that the pancreas starts putting out more insulin. So early on in the whole process, the insulin levels are going to be high in patients with prediabetes or early diabetes. And the extra insulin is trying to force the chewing gum, as it were, or the fat out of the keyhole. And it works for a while. And then the pancreas kind of runs out of gas, and it can't produce enough insulin to keep up with it. And then the sugars sort of gradually start creeping up, and you have type 2 diabetes. So that's the basic story about why we get this. And on 8, I do risk factors, but I say at the very beginning, the cause is not known about why this happens. We don't know why it happens. But there are some risk factors, and you can read about those. And that, the two that are, I suppose, the most obvious are people who are older, 45, 55 years old, and people who are overweight. And I suppose we could throw in a family history too. But there are other risk factors. And then I wrote down some things about how to reduce the risk factors on the same page. And the most obvious thing is to try to lose weight. Now, physicians, it seems to me, have a very, very hard time helping people lose weight, and they can't lose weight themselves, myself included. We just can't do that very well. So that's a real problem. But there are some meds that I list over here on page 10 that can help with that. And I've also included a chart that shows your body mass index, and you can figure out what yours is by looking at your weight and height. And you'll see what your body mass index is. And you'll find out if you're overweight, obese, or just really obese. Then, moving on, the National Institutes of Health has put out a little page that I included in this that you can use at home to see if you're at risk for type 2 diabetes. And it talks about your weight, family history, prior history of other diseases, and that sort of thing. And they have a little calculator here that you can calculate that risk. Now, moving on to symptoms, the most important symptoms are increased thirst, hunger, increased urination, and unexplained weight loss. And all of those things can be explained by really one thing. When our blood sugars go above 200, the kidneys start spilling sugar into the urine, just because that's the way the kidney works. And so you start losing fluid, you start losing calories, and your urine volume picks up. So you become thirsty, hungry, and you have polyuria, you have a lot of urination, and then you lose weight because you're losing an energy source. You're losing sugar from your diet just because it's going out in the urine. So that explains the big picture. There's a few other things there that are associated with diabetes as well that you can read about. Now, the diagnosis of diabetes, I've written down the criteria that are published by the American Diabetes Association. And I frankly think that these numbers are too tight. That is, I would elevate the numbers a bit because they just seem to me to be, a little low. But that's what the ADA says. Now, there's a condition called prediabetes where your blood sugars sometimes are elevated just a little bit. And some guys back in the 1960s thought that they ought to call that a disease, mainly to try to shame the patients into losing weight and making the, quote, disease go away. But just this year, there have been 2 studies that have been published that have shown that patients who have been diagnosed with prediabetes, very, very few of them go on to progress to overt diabetes. And so if you've been diagnosed with prediabetes, I'm not sure I'd worry about it too much. Although your doctor may jump up and down or whatever your doctor does. So now let's move on to the treatment of diabetes, type 2 diabetes. Well, the first treatment's always oral agents. And the one that is always used first is metformin. It's cheap, it's very effective, and you put people on that for several months, and then you start adding other medicines to it. And so you would have people do some blood sugars at home. You might do a hemoglobin A, have them take metformin for 2 or 3 months, come back to the office, see what kind of sugars they were doing at home, do another hemoglobin A, and decide if you need to add another medicine. And most people would add a sulfonylurea. They're cheap, safe, very straightforward to take. And do the same thing again, and have them come back 2 or 3 more months. And then if they're still having trouble, they would add a TZD. And there's a list of all these medicines over here on the opposite page that you can see. That some of them are injectable, and most of them are oral. At the end of about 3 of these drugs in combination, though, I think most endocrine people would say, if you're not in control, most people would say, look, why don't you just take a little bit of Lantus, which is a long-acting insulin at bedtime, and keep taking your pills, or maybe drop off the TZD and take the other 2 or something like that, and then see what happens. And often that will help. Often people will come in control with that. But if they don't, I think most endocrine people would just say, look, we tried all the pills, they didn't work, let's do insulin. And there are 2 kinds of regimens that can be used, and I'll talk about those in a minute. But one is called a split mix regimen. A split mix regimen is 2 kinds of insulins, which I'll talk about in a minute, are given at breakfast and at supper. And it was originally developed to treat type 1 diabetes. And the reason it was is because there was a peak. You divided the day into 6-hour parts, and you had people eat basically the same amount of food at the same time every day, and you gave them regular insulin in the morning with NPH insulin in the morning. And the regular insulin peaked in about 3 hours, which covered the breakfast. The NPH peaked in the afternoon, which covered lunch. Gave them another shot at supper. The regular covered supper, and the NPH worked overnight. And that really kind of worked kind of okay for type 1s, but it really never was quite what we wanted. But in type 2s, it's very effective. And it's not very hard to mix insulin in the same syringe. There are pre-mixed insulins available now that you can use. And so going to a split mix regimen is often will control type 2 diabetes. The problem with it is, though, you have to eat the same amount of food at the same time every day. Now, if you don't want to do that, you can go to a basal bolus insulin regimen, which I'll talk about in a minute. Now, let's move on and look at the insulins. There's a page over here on 15 that tells you all the insulins that are available. There are 2 companies that make insulin, Novo Nordisk and Lilly. And these are the insulins that we have. They used to make something called Lente, but they don't make that anymore. And all these insulins are human insulins. In the early days, we didn't know how to make human insulin, so the companies chopped up the pancreases of hogs and cows and extracted the insulin from that and put it in a bottle, and that's what you use. It purified it, of course, and so you were using, the most common was just a mixture of cow and pig insulin. Now, with recombinant DNA technology, we'll talk about in a minute, we make human insulin, and it's an amazing process. But anyway, you can see that there's some really very rapid-acting insulins. There's some that are intermediate, short-acting, some that are kind of a little bit longer-acting, and some that are very, very long-acting. And the way these insulins are made is if you extract insulin from a pancreas, you get regular insulin. And then the companies modified these insulins to make them act longer or shorter. So the first one, people have spent a lot of time in the early days of diabetes care and insulin use trying to make regular insulin last longer. And they had some luck with NPH. NPH means neutralized protamine hagedorn. Dr. Hagedorn threw in some protamine with the regular insulin, and then lo and behold, it lasted longer. And that's the kind of thing that Novo Nordisk and Lilly have been at for years. And then over on page 16, there's a profile of the different insulins, when they peak, how long they last, and so forth. And you can look at that. And then on page 17, this is the ADA position paper about how to treat type 2 diabetes, and it's just what I just told you. You start off with metformin, and then you add usually a sulfonylurea, and then you often add a TZD. And after that, you go to insulin. And that's kind of what things have come to pass. Now, on page 18, it shows you how human insulin is made. And basically what happens is that they take a piece of DNA out of a human pancreas that codes for insulin. Insulin is a protein with two chains held together with disulfide bridges. And there's down at the bottom of that page, there's a picture of human insulin with all the amino acids. So what Lilly does is they take out a piece of the DNA from a human pancreas, they incorporate it into something called a phage. A phage is a virus that infects bacteria. And so they infect the bacterium, and then they put this whole gamish in a big tank. And I've been out to the Lilly factory, and the tanks are enormous. They're as wide as this room or wider, and they're like 2 or 3 or 4 stories tall. I mean, they're just huge tanks. And they just let the bacterium sit in there and make insulin, human insulin. Then they empty the tank, and they take the gamish that's in there, and they basically, in the end, pour it through a column, a molecular sieve, it's called. It's chromatography for the chemists here. They pour it through a molecular sieve, and that separates out the proteins according to their molecular weight and size. And these columns that they pour this thing through are about this big around. They're huge. I mean, a little column in a chemistry lab would be about like that. You know, these things are huge, and they're about 2, 3, 4 stories tall. It's just amazing the way they do this. So then, you know, I talked about various insulins in terms of when they acted, how they acted, faster or slower, how long they lasted, and so forth. And these analogs are made. I put a little picture down here at the bottom of page 18 that shows you how Novo and Lilly sort of manipulate native insulin to make them last longer or shorter than regular insulin. And they substitute amino acids, they hang little side chains onto the insulin molecule, they do. I mean, the organic chemists are there just having a great time, and the protein chemists. Now, moving on to the next one, we show you a profile of a split mix insulin regimen. You see that there you take 2 shots, one at breakfast, one at supper. You take regular insulin, which peaks in about 3 hours, lasts about 6. MPH peaks in the afternoon. And you do the same thing at supper. And you have basically 4 peaks of insulin. And that really works extremely well in most people with type 2 diabetes. And usually you use a third of regular and 2/3 of NPH in the morning and half of each at supper. And it turns out that the companies make that proportion of pre-mixed insulin. So you can buy the stuff pre-mixed. You just have to work out the dose. And that's what your doctor or an endocrine person would help you with. But you have to eat the same amount of food at the same time every day because you don't change the insulin. So people have not been very happy about that because some of us like to eat breakfast and then one day and then not the next day, and one day we eat a lot of breakfast and the next day we don't eat very much. And so when we got some new insulins, they came up with the basal bolus regimen that's shown on the bottom of that page. And what you do there is you take a shot of very long-acting insulin like Glargine at bedtime, and then you take a very short-acting insulin, peaks in about an hour before each meal, and you do carb counting. And what you do, and people get really pretty good at doing this, you look at your breakfast plate and you figure out that, this clump of potatoes and this clump of eggs and whatever you're eating there is worth 3 carbs, let's say. I'm just picking that out of there. And you know for yourself, because it's different in everybody, that if you take let's say 5 units of really very rapid acting insulin when you eat or even after you eat, that'll keep your sugar down after the meal. And that number's different for everybody, and it'll vary with the meals as well. But people get pretty good at doing that, so they'll come along and they'll take their long-acting insulin at bedtime. They'll have their little insulin pen that has a short-acting insulin in it, and they'll go eat, and then they'll give themselves a shot of really very very fast-acting insulin, and it'll keep the sugars down. And that way they can eat different amounts of food at different times of the day. They're not hogtied into trying to eat the same amount at the same time. And that's been very, very helpful. And then that ties really into insulin pumps. You've heard of insulin pumps. There are 2 kinds of insulin pumps. There's a open loop pump, and the open loop pump pumps a certain amount of insulin per hour all the time. And you can vary that. Sometimes you pump, let's say, half a unit an hour until 10 o'clock at night, and then you program the pump to pump 3/4 of a unit an hour overnight, because most people need more insulin overnight. We're not sure why that happens, but it may be that your adrenal cortisol level is starting to rise overnight, and that causes insulin resistance, and so you need more insulin overnight. But that's another story. So anyway, but the pump can be varied. The basal rate can be varied. But you have to tell the pump how much to give you before each meal. But you don't have to give yourself a shot because it's already hooked up. You just tell the pump what to give yourself. And that's really a basal bolus regimen as well. But now what's happened is that they've developed continuous glucose monitors and sensors that can be implanted in your skin, and they will read your blood sugar usually about every 5 minutes. And you can ask the thing what your sugar is anytime with your telephone if you want to. And but it sends a signal to the insulin pump about what the sugar is, and then the insulin pump has been programmed with a control algorithm to deliver a certain amount of insulin. So let's say at 8 o'clock in the morning your blood sugar is 100, and then you eat, and then at 9 o'clock it's 150, and the control algorithm then says, well, you need to increase the amount of insulin that you're pumping continuously to get that sugar back down. But then it's reading the sugar you see every 5 minutes, so when it comes back down, the insulin, the pump starts pumping less insulin. So the whole thing is kind of automatic. I mean, it's almost like a artificial pancreas, which everybody would love to be able to have. And that's been a big advance, that technology. And it's all about electrical engineers and electronic people and all that kind of stuff. Chemists, making these things. Okay, so that's kind of it for that. Now, blood sugar testing, you know that most people with diabetes test their blood sugars. They have a little glucometer. And there are a zillion glucometers on the market now, apparently. And there's some that are very simple and straightforward to use. There's several that are very cheap. There are others that are very expensive. Some have a lot of bells and whistles, and others don't. And you just have to go and find out what kind of thing you want and what your insurance will pay for. And keep in mind, if the if the meter uses a strip, you find out how much they cost too, because usually that's the big. They almost give away the meter for you to buy the strips. What I used to do, the question is, how often should you check your blood sugars? Well, if somebody with type 2 diabetes who's stable, let's say on an oral agent regimen, taking 2 pills or a split mix regimen or something like that, a lot of those people are pretty stable. I mean, they try to eat the same amount of food at the same time each day. They do about everything the same every day. And so they'll have blood sugars that are, 70 to 130 or something like that. So you really don't need to check your blood sugars, in my judgment, very often. I mean, it's a big pain to prick your finger and all that stuff. So I used to tell patients to do breakfast. There are a lot of ways to do it, but do before breakfast on Monday, lunch on Wednesday, supper on Friday, bedtime on Sunday. Or do just 2 a week. Do breakfast on Monday, lunch on Friday, then the second week do supper on Tuesday, and end of the week do bedtime. And write those down, and you'll get a nice picture of what's going on with you. Now, if everything is unstable for some reason, then you need to check more often. But routinely, I think doing it, a few times a week is enough. And the reason it's enough is because you can come back and find out what the average blood sugar has been over the past 2 months or so, 2 or 3 months, by doing a hemoglobin A. And you see that advertised all the time on TV. We have a new drug out that lowers your hemoglobin A. Actually, most of these ads that I've been running recently are Me Too drugs. They're drugs that act like some of the old agents that are a lot cheaper. But they're always talking about lowering your hemoglobin A. Well, what is hemoglobin A? Well, hemoglobin A is hemoglobin with a sugar attached to it. And what happened, red blood cells are freely permeable to sugar. You don't need insulin to get sugar into a red cell. So the concentration of sugar inside a red cell is the same as it is out in the blood. So the sugar is going back and forth just all the time. And the rate at which the sugar reacts with the protein is linear, so that when the sugar is high, a lot of sugar is reacting with the protein. When the sugar is low, not so much. And of course the sugar is going up and down all the time, like that. And the rate of the reaction is going up and down all the time. It's kind of calculus, you know. Yeah, integrate to infinity. But it's been an incredibly useful test to kind of find out what your average sugar has been like over the past several months. And this thing was discovered by accident back, I think, in '69 or something like that. Some guys were looking at hemoglobin variants, like, for instance, hemoglobin in sickle cell disease. They were trying to find new hemoglobin variants, and they were running samples on an electrophoresis plate, positive, negative charge, and they'd run it, and the molecules would move across the plate. What they found was that there was this strange new hemoglobin that they'd never seen before. And it turned out, and they went back and looked at, where they got this stuff from, and it turned out that all those people had diabetes. And then the organic chemists and the biochemists and all those guys got together, and they figured out that what was happening was that sugar was reacting with hemoglobin, producing a covalent bond of the sugar to the hemoglobin. And you can see the reaction down at the bottom. Glucose reacts with N-terminal group on the beta chain of hemoglobin and forms a Schiff base, or for the chemists, that's an aldamine. And then there's this miraculous thing called an amidori rearrangement. And lo and behold, and presto, the sugar is covalently bonded to the hemoglobin, and it will not come off. It is there. Well, that's interesting. And if you go to the next page, you can kind of see what this is doing. This is a profile of a day. The sugars are going up and down. But what the hemoglobin A is telling you is what the average sugar is, without you having to do, 10,000 measurements. I mean, if you want a very accurate average of blood sugars, you'd have to prick your finger, 200 times a day, for goodness sakes. Well, the hemoglobin A will tell you what the average blood sugar is. And I've put a list down there. If you have a hemoglobin A, say, of 10, the average blood sugar is 240. So it's very useful to endocrinologists and physicians. That number is very, very helpful in helping people decide whether they're doing the right thing in terms of trying to control their diabetes. And we'll come back to that, because that's going to be important in something else in a minute. But anyway, as you know, there are complications that can occur with long-standing diabetes. And I've made a list of them there on page 24. The things we think about as sort of exclusive to diabetes are usually peripheral nerve damage, renal disease, kidney disease, and eye damage. But there are some other things that are going on as well, as you can see. And the question is, why is this happening in the first place? What's the biochemical mechanism for this? Well, on the bottom of page 25 and on page 26. I talk about that a little bit. When hemoglobin A was discovered, the chemists, the organic chemists, the biochemists, the internists, the endocrinologists, and all those people wondered whether or not the reaction of sugar with a protein was the basis for the complications of diabetes. And that unleashed a torrent of research. The NIH has spent $1 zillion in various labs trying to figure that out. And they have figured out a lot about it so far. And it turns out that this process is fairly common. Sugars react with proteins all the time. When I was at Duke, we collaborated with, I worked in a lab that really did protein chemistry. Bob Hill was a protein chemist. And we collaborated with a group at the University of South Carolina to look at the glucosylation of serum albumin, and which was very interesting. And so this stuff really kind of reacts with a lot of different things and a lot of proteins. And I'll show you in a minute some of the problems that creates. But there are kind of two kinds of things that happen with this process. One is that the sugar can react with a protein either floating around in blood or maybe a structural protein like collagen, or maybe a basement membrane of a kidney, or maybe other structural proteins. And a lot of these adducts of sugar have been identified, although the identification of the sugar on a protein is very hard to do biochemically and chemically. The chemists have spent a lot of time trying to figure out how to do that. And I don't think yet they have a good way to do it. So you can't just take out a piece of tissue and throw it in a chemistry flask and figure out if there's sugar attached. It's more complicated than that. But what people did realize is that when you have collagen molecules, which is a big part of our skin, and those molecules are usually arrayed parallel to one another. When sugar reacts with one of these molecules, it also can react with an adjacent molecule and cause cross-linking. And if you flip over to page 29, we're going to come back in a minute. That shows you the glycation process. And Americans call this the Maillard reaction. It was actually described by a Frenchman and Louis Maillard, actually. But what happens is that sugars attach to a protein, and then they attach to adjacent protein, and they cross-link the proteins. And it seems that in the case of collagen, when that happens, these parallel collagen molecules that you had are kind of pulled apart, and they go kind of like that. And then that causes wrinkling. And in fact, some guys uh, created in an animal diabetes and let the animal sit around for a while. And they noticed they had a way to measure skin changes. And they measured that, and they, thought, well, this looks like, skin aging to us. And then they found a compound they could feed the animal and go back and see if the skin aged, and lo and behold, it didn't, because that compound blocked the reaction of sugar to the protein. And so it prevented wrinkling and prevented aging. So, can you imagine now that doctors and pharmaceutical companies are driving themselves crazy trying to find a compound that will prevent this reaction? Because if you do, you can potentially prevent the aging process, and also you can prevent the complications of diabetes because you're not glucosylating any proteins. And so then you don't have to keep the sugars very tightly controlled, as it says over on page 27, which is how do you prevent complications? Well, the biggest thing is to do good control of diabetes. There were two very large studies done that were supervised by, among other people, a guy that was at Duke, Jay Scholar, who called the Diabetes Control and Complications Trial. And they did one for type 1 diabetes, and they did one for type 2 diabetes. And lo and behold, people who were in very good control of their diabetes had much fewer complications, almost none, in fact. And people who aren't had complications. So it's the sugar that's the problem. So that's the biggest thing. But, there are some other things there too. You want to lower your lipids. You want to treat any vascular disease. Maybe take an aspirin a day if your doctor tells you to. Treat your blood pressure, lower your cholesterol, and all that stuff. But it's really the control of the sugars that makes a difference in complications in diabetes. And as you might think, if you have uncontrolled diabetes, you might age more quickly, which seems to be true, actually. I mean, there are some investigators that have looked at markers for aging and have found that people in poor control seem to age more rapidly. Well, that brings us to, the whole idea. Well, I mean, if we could find a compound to prevent all this stuff, could we live to be 120 or 150? Or, I mean, do we want to live to be 120, 150? But there's some serious people out there thinking about this, and some labs that are working on it. And so I find that I find this whole business that kind of evolved out of type 2 diabetes to be really fascinating, because it sort of broadens the whole idea. How do we prevent complications? Then that leads to aging. I mean, it just kind of goes on and on. And so there's some exciting stuff that's being done, and we should keep reading the paper. Maybe we'll find out about somebody who's discovered something. So I think that kind of gives you the big part of it. I was going to mention one other thing, that insulin has been, since I'm a biochemist, or was a biochemist, I wasn't a protein chemist though. Insulin has been very, very important in the history of biochemistry. Banting and Best, of course, discovered this stuff in 1921. And then a guy named Peter Maloney in 1922 figured out how to purify the stuff. And purification of proteins is a big part of biochemistry. I mean, people have these columns, and they run columns, and they do all kinds of stuff to purify stuff. And the guy I worked for when I was at Penn, had something called a countercurrent distribution device. I won't get into it, but it was a huge machine with all kinds of glass things on it, and it rocked back and forth. And as it did, liquid went this way, and the proteins went the other way, and they got purified. They don't use that anymore. And then in '58, a guy named Fred Sanger worked out the amino acid sequence of insulin. Proteins are sequences of amino acids. And he was the first one in '58 to work out the sequence for protein, and the one he picked to do was insulin. He got the Nobel Prize for that. So insulin has been very important in biochemistry. It's obviously very important in our lives. And at the end, I put down some, there's a lot of stuff on the web that's very, very technical and very, very simple and straightforward. The various websites have geared it to various audiences, and they will tell you who they're talking to. Like if you go to the Mayo Clinic site, it'll tell you that this is for professionals, this is for patients, this is for the curious that are just dropping by, whatever. And they try to make things fairly straightforward, and so. And I hope the handout is straightforward. I tried to make that sort of straightforward, but a little bit entertaining as well. So I think that's kind of all I have to say. But I'm happy for questions and whatever people want to ask, talk about. I may or may not know the answer. Oh, you know, I'll tell you, there's one other thing I want to talk about. We moved over here in July of last year, and you know, it occurred to me then that there are two medical disorders that I think are important for all of us who are over 50 that are overlooked. And one of them is vitamin D deficiency, and Dr. Wilson over here wrote a very nice piece about that and about what you should do about that and how it should be tested and all that kind of stuff. And the other one is hypothyroidism, which is different from the diabetes. But people become, as you age, there are a fair number of people who become mildly hypothyroid, and that's going to affect their cognitive abilities sometimes. Well, there was some person here who thought that, and I suggested, well, maybe you ought to have a thyroid blood test done, you know, every now and then, every 5 years, I don't know. And so, but somebody had one done, and lo and behold, they were aghast that they had to pay for it themselves. So the question is, when will the insurance company pay for it and when will it not? Well, there are basically two reasons an insurance company won't pay for a test. The first one is you've not met your deductible. And the second one is that the doctor coded the whole business the wrong way. So if you came into the doctor's office and said, you know, I dropped a frying pan on my foot this morning, can you take a look at it and make sure it's okay? And you order an x-ray of your foot, then the insurance company will pay for all that. If you came in and said, well, I dropped a frying pan on my foot, and I said, oh, that's interesting, and I ordered a thyroid blood test, they wouldn't pay for that. And they'd say, you know, well, what's going on here? Why are you ordering a thyroid blood test when the problem is an injured foot? Well, that makes sense to me. But let's say somebody came in and said, look, I dropped a frying pan on my foot, and the reason is, you know, I've been so tired over the last 2 and I've gained weight, and I have really dry skin, I have all these kinds of problems. and you ordered a X-ray and then a thyroid blood test, but you included a diagnosis, injured foot, and symptoms perhaps related to hypothyroidism, then they pay for it. That's called coding. And we had just a tremendously competent woman in our office who made sure that anytime we saw or did anything for a patient, it was all coded the right way to make sure that we got paid and to make sure that the patient didn't have to pay for it if they didn't have to pay for it, for a deductible, let's say. So, I mean, there are plenty of ways that doctors can get stuff done and have the insurance company pay for it. So, questions? Oh, Sandra.
Where I go for my physical, they always do the blood work a week before you see the doctor. So I never pay I always pay for the thyroid test. That seems unfair from what you've said.
Well, it does, and I think what you ought to do is talk to your doctor about it. There is no code, as far as I know, that would look at asymptomatic people, let's say, over 65. There should be a code like that, but there isn't, I don't think. But, I get tired all the time. Hey, doc, I'm tired. Could I have a thyroid problem, you think? Oh, gee, I don't know. Maybe. Dry skin? Yeah, oh, yeah, kind of dry. Doctors can be clever at getting things done that should be done. You know what I mean? I think, anyway. But yeah, that's the problem. But it's interesting. I go to the VA clinic here. I'm an old vet, and the VA clinic here is really a very good clinic, as a matter of fact. Tremendous health records and all that kind of stuff. And they do stuff every year for me, and they include a vitamin D level and a thyroid test now, routinely. That's part of the whole thing. That's just like doing a complete blood count or, chemistry profile, something like that. That's just part of what they do. So maybe Medicare will come around.
Dr. Guthrow, in your years of experience, do you recognize any difference between the generic and the brand medications for thyroid?
No, not really. Synthroid was the first pure thyroid hormone that we had, and it's T4. Before that, we had desiccated thyroid. Armour chopped up thyroids from animals and extracted the hormones. It's like they did insulin, or in the early days. And then people, the organic chemists figured out how to synthesize thyroid hormone because it's not a protein. It's an organic molecule, and the chemists can make that in a lab, and they can make it commercially. And so they first started making pure T4, which is Synthroid. And the argument against the argument for using that is that in the desiccated thyroid preparations, there were different combinations of T4 and T3, which are the two thyroid hormones. And so that might vary batch to batch. But if you gave people pure T4, then it was always the same. And the people who are making Synthroid spent a lot of money trying to convince doctors that their preparation was great when their patent went off. But I've had lots of people on generic Synthroid and generic thyroid hormone that just do fine. I've never saw any difference really. Yes.
Can I ask
Jerry.
you? May I ask? I enjoyed the lecture very much. Thank you very much for taking the time. But has anybody looked at trying to reverse this glycylation reaction to reverse aging?
Oh yeah.
Well, I mean,
Yeah.
we got a vested interest in here. So.
Well, yeah, they have. I mean, and in fact, we found when we were working with these guys down in South Carolina that aspirin would inhibit the glycation of albumin. Not very much, but it did do some. And also vitamin C will do it. And also, they've found that let's see, vitamin E will also do it in some people. But I would caution people about taking vitamin E because it's associated with prostate cancer. So you ought to be careful about that. There is, in Parkinson's disease, in Alzheimer's disease, there are these little tangles of amyloid that are deposited, which is a protein that's deposited in your brain. And so some guys said, well, gee, I wonder why they aggregate like that. I mean, could it be cross-linking? And could it be related to sugar hooking on these proteins and then cross-linking these amyloid proteins together? And then the stuff just glops out in your brain, and then, pretty soon you have a disease. And it turns out that there is some cross-linking to the amyloid. And it turns out, too, that naturally occurring phenols will inhibit that reaction. Well, phenols are in olive oil. So just load up on olive oil, and maybe that'll help. So there are some things out there like that that'll inhibit that reaction. But that's going to be, I mean, if I were a 22-year-old chemist or biochemist and knew all this stuff, I'd say, gosh, man, that's where I ought to be putting my energies in, because it's the people who figure this out are going to either make a lot of money, win a Nobel Prize, or both. And, so. But the phenols will do it from, at least for the amyloid stuff anyway. Question? Yay! Everybody got a handout? Oh, great. Okay. We got enough.